morning. Today we'll be talking about survivorship. You see, as medical professionals, we treat cancer and focus on medical care. And there are few things which are beyond usual physical care or the medical care. And today we are going to cover cancer survivorship. See what happens after the diagnosis, what happens after the person is cured. There are other issues which need to be addressed. So before we hand over the mic to Dr. Rima, I'll request the moderator, her mentor, Dr. Nayak, to just give a head start and introduce the topic before she starts the discussion. Over to Dr. Nayak.
Thank you, Dr. Devan. Cancer survivorship is a very dear topic to us, especially because we've been running a very successful laryngectomy laryngeal cancer survivorship program for the last 25 years. In fact, we recently celebrated its 25th anniversary. It's basically very much akin to the topic which Dr. Rima Joseph, our first FNB head neck surgical oncology fellow, is going to present upon. I am a senior head and neck surgical oncologist at Apollo Cancer Institute, Hyderabad. And this particular laryngeal cancer survivor self-help group which we started is based on the concepts which some of the things she's going to talk about. It's about how people are able to, or how we can support them in their subsequent course in life once they have survived their cancer. So in this particular laryngectomy society which we have a very comprehensive rehabilitation and physical, social, psychosomatic, vocational, including voice rehabilitation programs for these patients. We don't call them even patients, we call them survivors. And we try to avoid using the word that they are patients or such terms. In fact, some of us even feel that we should not even use the word survivorship because that also indicates a stigma. We prefer to call them members of the society. So this is not a new concept. It has been there for in many hospitals, but we developed this program, and we have this program in which every month, not just the survivors, their family members, the medical team, everyone gets together, meets, brings out some of their concerns in addition to doing the rehabilitation program. And we have found that such self-help groups do a lot of benefit to such programs in which you are trying to get people out of their fears and anxieties after they have survived the cancer. And this is not a concept only for laryngectomy survivors. It is there in many other aspects of cancer care, such as you have the breast cancer survivor groups, you have colostomy societies, and many more. So I like to give the analogy of somebody alone walking in a dark street at 2 a.m. in the morning. Now, compared to that, just imagine that you are walking in the same dark street at the same time with 10 other people. You're not scared anymore. The fear is gone because you have people who have gone through similar things with you. So that is what a self-help group is the basic concept of, that you have people who have gone through the same thing as you, and you are not walking the street at night alone. So the fear is less, the anxieties are less, and these people have a long way to go because there are a lot of cancers in the head and neck region and in other parts of the body wherein the cure and survival rates are very high, and that numbers are increasing day by day. So these people need to be able to get back to society, get back to their vocation in a way in which the anxieties, the fears does not compromise on either in their lifestyle or their quality of living. So with this brief introduction, I would request Dr. Rima to talk about the subject, and then maybe we can have a discussion at the end of the presentation.
Good morning, everyone. Today's topic of discussion is cancer survivorship, and I'm Dr. Rima Joseph from FNB Fellow, Apollo Hospital, Hyderabad. So, living beyond cancer into long-term survivorship is now a reality for most of the patients who are diagnosed with cancer. The number of cancer survivors continues to increase as both advances in early detection and treatment as well as aging and growth of the population. The number of cancer survivors has dramatically increased from 3 million to up in 1971 to approximately 32 million now. So, the cancer survivorship was often a neglected topic until 1985 when Dr. Mullen has written, who is a physician as well as a cancer survivor, who has written a letter to NEJM urging the need to consider cancer survivorship as a separate phenomenon. So, in order to deal with the medical and social hazards associated with cancer treatment and later on survival. The definition of cancer survivor: an individual is considered as a cancer survivor from the time of diagnosis through the balance of his or her life. Family members, friends, and caretakers are also affected by survivorship experience and are therefore included in this definition. It includes both patients who are currently undergoing treatment as well as those who have become cancer free. So, with a change in etiological pattern of cancer causation in subsets such as oropharynx, the projected incidence of oropharyngeal carcinomas will be approximately 70% of all head and neck cancers by 2030. And because the etiological factor is a human papilloma virus associated tumor, and it has a survivor of approximately 90% across all the stages, and they present at an early age. So we have to support them as they are in their active workforce and plays a vital economic role in their families. So this shows the various proportion of cancer survivor in it's actually a US population study, and they have shown that most of the cancer survivors belongs to the group of breast cancer followed by prostate cancer, and in head and neck cancers the most common cancer survivors are thyroid cancers, and others constitute less than 7% of the survivors. And as the number of long-term cancer survivors continue to increase, oncologists and other clinicians must understand and address the complex interplay of their biological, psychological, and socioeconomic needs. The biological sequelae often includes the disruption of organ function and causes tissue-specific and systemic comorbidities which can be life-altering. Example, infertility, hearing loss, or life-limiting like cardiovascular diseases and second malignancies. The psychological sequelae includes depression and distress from fear of cancer recurrence and failure to work effectively and to socially engage with others, and this can affect the life satisfaction. The socioeconomic consequences such as insufficient income and high cost of medical care and bankruptcies may be as that will cause the difficulties associated with daily living. So, the multifaceted need of survivors demands a spectrum of action from clinicians in order to ensure quality survival. Clinicians must not only diagnose and treat the chronic physical effects of cancer and its therapy, but also promote adaptive and rehabilitative lifestyle changes and campaign for fair socio-economic treatment by the society. The process begins with communication between the clinician and survivor regarding the details of treatment, potential sequelae, and guidance for ongoing follow-up care. So, this terminology of acute survival, extended survival, and permanent survival was first coined by Mullen in his article in the letter Seasons of Survival. So he defined acute survival. It is a period from the diagnosis to the end of cancer treatment. And in this stage, the patients will have fear and anxiety of cancer diagnosis, diagnostic and therapeutic procedural consequences, and psychological burden to deal with their mortality. The extended survival starts at the end of cancer treatment. The endpoint of extended survival can be varied based on cancer, but it is usually considered as 5 years of disease-free interval. So in this time, in head and neck cancer patients, the concerns primarily consist of surveillance for recurrence and second primary tumors and functional sequelae of therapy. Next one is permanent survival. Permanent survival is considered from point of cure, that is likely 5 years of disease-free interval to the end of life. This includes, this time the patient may have the fear of second primary cancer and coping up with new social and familial roles, and also extended treatment sequelae. So in the cancer control continuum, the survivorship should be considered as a separate entity. So specific goals to optimize outcome for cancer survivors includes raise awareness of medical and psychosocial problems faced by cancer survivors and establish cancer survivorship as a distinct phase of the cancer care trajectory. And the second one is define quality healthcare for cancer survivors and identify strategies to achieve it. And third one is improve the quality of life through policies to ensure that cancer survivors have access to psychosocial services, fair employment practices, and health insurance. So this is given by Institute of Medicine, which includes the essential components of essential components of survivorship care. So first one is education of the cancer survivor, family members, and healthcare providers. That they should be educated regarding the care based on treatment administered and future health risks, promotion of healthy lifestyles, so information to assist healthcare providers in understanding future risk and to foster an effective interaction with the oncology team. The second component of cancer survivorship care includes surveillance for cancer spread, recurrence or second cancers, and for long-term adverse effect of the cancer treatment. Third one is intervention to prevent or treatment consequences of cancer or its therapy. Fourth one is communication between specialist and primary care providers to ensure that survivors' health needs are met and detailed records are kept about treatment history. Another one is research, which is focused on understanding, research, and preventing and treating adverse consequences of cancer or its therapy, and patient advocacy to address the problems related to employment, insurance, and disability. So coming to the survivorship care in head and neck cancer, the survivor should be supported during all the phases of cancer survival. So first one is the effects of cancer and its treatment. The head and neck cancers have the potential to affect various vital functions such as speech, chewing, and swallowing. Both surgical and radiotherapy treatment modalities can affect swallowing and breathing functions. Post-radiation effects like xerostomia, then post-RT dysphagia, osteoradionecrosis, etc. must be cared during the period of survivorship, and almost 50% of survivors suffers from cancer treatment-related sequelae. The physical effects, these are often neglected factors. These constitute effects that are related to cancer therapy but are not direct consequences of treatment, like loss of stamina, loss of weight, and fatigue. And almost 38% of cancer survivors have physical effects that are often unrecognized by the treating physician. Next one is second primary cancers. The risk is based on various factors such as genetic susceptibility, shared causative effect, and mutagenic effect of cancer treatment. So all cancers, 8.1% of cancer survivors develop second primary cancer in a meantime of 7.1 years, and 55% of them die as a result of second primary cancer. In head and neck cancer, the rate of second primary cancer per year is 3.7 to 6%, and the risk is persistently high even after 10 years, with a cumulative risk of 36% at 20 years. And most of the second primary cancers in head and neck cancers are found in the upper aerodigestive tract, which constitute 40 to 59%, lungs, which is approximately 30 to 37.5%, and esophagus, which is approximately 9 to 44%. The prognosis of second primary cancer is poor. So we should implement various strategies, which includes the chemo prevention and routine screening methods, but it is found that it has variable results. And lifestyle modifications also play an essential role in preventing cancer recurrence and second primary cancer. Tobacco and alcohol cessation forms an important component of survivorship care, especially in head and neck cancers. Next one is psychosocial effects. Most patients do suffer psychological stress, especially during the early phases of cancer. 19% of cancer survivors fit the diagnostic criteria of post-traumatic stress disorder. Psychosocial support during and after cancer therapy is essential in maintaining the compliance of the patient during the so that they will be able to do the cancer treatment completion, and they will be able to come for the regular surveillance visit. Fear of recurrence. So about 70% of cancer survivors have reported to have fear of recurrence, which can cause significant psychological distress. Cancer survivors with increased fear of recurrence have shown to have lower quality of life and are often more depressed. Employment issues. They have to return to work after cancer treatment, and that is based on their socioeconomic factors, cultural influences, and cognitive status of the survivor, morbidity result from cancer treatment, and also the psychological status of the patient. In India, where most of the head and neck cancers are from low middle income background, they have shown that 65% of them return to work by approximately 6 months, and by 19 months, 81% of the patients will return to work. And financial burden. The Livestrong survey in 2012 has shown that approximately 33% of working age survivors were in debt, and 3% had filed for bankruptcy by the end of the treatment. And financial burden plays a vital role in psychological status of the patient and for maintaining a good quality of life and adherence to treatment and surveillance. So goals of survivorship healthcare. So first one is identifying the late effect of cancer therapy, the potential to ameliorate or prevent normal tissue damage or to manage and rehabilitate affected patient requires an understanding of this persistent long-term or late onset chronic effect. Because the late effect can manifest months or years after cessation of treatment, therapeutic decisions to think about that effects can be based only on the probability and not the certainty that such effects will develop. So determining the frequency and pathogenesis of late effects is often difficult because a patient must survive that long for the tissue injury to develop. The second one is number of patients both affected and unaffected by therapy must be known, and latent period to the manifestation of damage compromises discernment of the responsible component of multimodality therapy. And cancer, for the late effect to develop, the cancer and host factors interact with therapy sessions. So cancer factors include direct tissue effects like organ invasion such as the lung, systemic effect of cancer induced organ damage or loss like hepatic dysfunction or renal dysfunction, and indirect mechanical effects like renal or airway obstruction and all. Host factors includes genetic, which includes can therapy, ataxia, telangiectasia, conditions like that, and comorbid conditions like vascular diseases, diabetes, and developmental age at treatment, and undergoing structural abnormalities, example cardiac abnormalities by the end of the treatment. So how do we do surveillance and guidelines for late effects? Treatment-related sequelae can often occur at any time during or after therapy and may be clinically silent during the initial stages. Some chronic or late effects can evolve during normal development or aging. The need for standardized guidelines to direct follow-up care after cancer treatment and surveillance for late effect of therapy is an important component of cancer care. So this shows the surveillance period and surveillance guidelines by various associations. So in surveillance, in UK guidelines, they are doing a minimum surveillance of 5 years and more than 5 years for high risk group. And in the first and second year, they are doing a surveillance every 4 to 8 weekly, and from the year 3 to 5, they are doing surveillance every 3 to 6 months. And for long-term physical and treatment-related side effects, they have done a head and neck cancer multidisciplinary team for assessing the treatment-related side effects regularly at each follow-ups, which includes the speech and language pathologist, the oncosurgeon, the radiation oncologist, like that. And long-term psychosocial effects. So these psychosocial effects should be assessed regularly at each follow-up and guided by a map of medicine. And health promotions include healthy nutrition, oral care, physical activity, tobacco cessation, body weight, maintenance of body weight, healthy lifestyle, oral care, like that. And care coordination in UK, they have found that clinical nurse liaise between the caregivers and head and neck multidisciplinary team. And in our hospital also, we almost follow the same protocol. So what are the interventions which can be done to prevent potential late effects? A growing number of studies have been designed and conducted with the intent of treating health conditions that are identified during or after the completion of therapy, as well as preventing late occurring conditions. Randomized clinical trials have tested the effectiveness of a wide range of interventions, including those aimed at increasing level of physical activities, promoting healthy diets, and smoking cessation, and reducing the adverse psychosocial outcomes. Many interventions has found to be effective at reducing the psychosocial morbidity such as depression and anxiety in cancer survivor, including behavioral and pharmacological approach. Post-traumatic stress in survivors is also a concern for which interventions has been identified. This should be tailored according to the treatment effect and the primary cancer for which the treatment has been taken. So next one is promotion of adjustment and healthy lifestyle. The potential for positive modification of lifestyle behaviors following a cancer diagnosis and treatment in adulthood is an opportunity during which cancer survivors may be open to make significant changes in their health habits. Comorbid health conditions that are highly prevalent among cancer survivors. So we can take an advantage of the teaching moment which occurs when patient transition from active cancer therapy to follow-up care. It plays an important role for survivorship. So although a substantial proportion of cancer survivors may be willing to initiate positive lifestyle changes as they transition from active treatment to survivorship, there are known groups of survivors who are less likely to adopt healthy lifestyles, those with lower educational levels. And these people needs additional support and intervention to achieve a positive lifestyle modification. So care plans in cancer survivor patients. The Institute of Medicine recommended that upon discharge from cancer treatment, every patient should be given a record of all the care received and important disease characteristics, and continued with the assertion that every patient should receive a follow-up plan that is clearly and effectively explained. These documents are intended to communicate the survivor's treatment history, to delineate a plan to ensure that the survivor receives appropriate follow-up care, and to specify which caregivers will provide which services. So this shows the survivorship care plan. So on discharge from cancer treatment, every patient should be given a record including contact information for each treating institute and key individual providers, which include the doctors and includes the doctors. Date of treatment of initiation and completion of the treatment, diagnostic test and results, tumor characteristics, surgeries or other therapies provided, including specific agents, regimens, dosage, number and title of clinical trials, if any, treatment response and toxicities experienced, psychosocial and nutritional services provided, identification of a coordinator of continuing care. So, on discharge from a cancer treatment, every patient and his or her primary health care provider should receive a written follow-up care planning, including the likely course of recovery from treatment, recommended periodic testing and examination by whom and on what schedule, possible late and long-term effects of treatment and symptoms, possible signs of recurrence and second tumors, possible effects of cancer on daily life like personal relationship, work, mental health, and available resources for support, potential insurance, employment, and financial consequences of cancer, and referrals to counseling, legal aid, and financial assistance if needed, recommendation for healthy behaviors that should also be shared with their first-degree relatives to minimize their potential risk of cancer, as appropriate information on genetic counseling and testing to identify high-risk individuals who could benefit from more comprehensive cancer surveillance. In head and neck, that includes like thyroid cancers, as appropriate information on non-effective chemo prevention strategies for secondary prevention, referrals to specific follow-up care providers, a listing of cancer-related print or online information resources and support organizations. So educational consideration, educating the cancer survivor, healthcare provider and family is critical to promote cancer survivorship, enhancing research. The growing and rather heterogeneous population of cancer survivors provide novel opportunities for research in many domains, including etiopathogenesis, screening, and early detection of adverse outcome and impact on quality of life. This population lent itself to research regarding these issues because of the ability to assess therapeutic exposure accurately in terms of both the exposure and its timing, and to examine the role of host characteristics. So in survivorship advocacy, employment, work and ongoing access to healthcare are primary areas of difficulty for survivors, and cancer-related financial burden can be substantial. So employment problems can impact many other people if the survivor was the main breadwinner. Even among those who are able to return to work, there may be discrimination that is either overt or an understated perception that cancer survivor is not well enough to perform his or her job at the highest level, or would be unable to tolerate that added responsibilities entailed by promotion. Insurance. To be effective, health insurance options must be available, affordable, and adequate in coverage. Advocacy, several non-profit organizations, these are international organizations such as ACS, Cancer Care, and National Coalition for Cancer Survivorship provide advocacy for the issues that affect cancer survivors. In addition to advocating more research funds and resources for survivor care, some of these organizations provides education, counseling, links to legal contacts, and other types of assistance to survivors with employment, insurance, or economic issue. So there are a few programs run through the government and charitable organizations that offer limited financial assistance with expenses incurred during cancer treatment or transportation to medical appointments. So Indian Cancer Society is one of such organization which is practicing in India, and it is established in 1951, and they provide vocational training, employment opportunities, and helps them with the psychological and social aspects of the cancer care. And UGAM is a support group from the Indian Cancer Society for pediatric cancer survivors. And programs are also offered by several pharmaceutical companies to provide patients and survivors with the support for expensive long-term outpatient medications. Providing information about resources available to cancer survivors to help them deal with this non-medical issue is a recommended component of the survivorship care plans. So, what are the barriers to survivorship care? It includes fragmented systems, poor coordination of care, lack of identified clinician for follow-up care, deficits in structures for coordinated communication, lacking surveillance guidelines, lack of effective survivorship delivery of care model. So, the cancer survivorship should be done at all the levels, which includes individual levels, interpersonal level, organizational level, community factors, and policy factors. This all should be in correct proportion in order to give adequate effect for the cancer survivors, for their health promotion and disease prevention. So, in Latin, the word cure means care. So, survivorship, even though it is coming up and it has made a substantial progress, it is still a young science, and it has already made some understanding of the multifaceted needs of ever-growing and vulnerable population of cancer survivors. The sobering physical and psychosocial and socioeconomic correlates of successful therapies are their long-term consequences that can compromise the quality and quantity of life for survivors and their families, friends, and society. It is the obligation of healthcare providers to critically assess and study these adverse effects and intervene whenever possible. With that, I'm ending my discussion. Thank you.
Very well done, Dr. Ima.
Thank you, sir.
And let me see if there are questions in chat box. I think by the time we wait for the questions, Dr. Nayak, would you like to add or your opinions?
Yeah, I would like to make two important observations. Prima has covered the subject very comprehensively. One is about the point she made about the fact that 70% of cancer survivors, even after they're technically probably cured of the disease, still have a lot of apprehension about the fear of recurrence. So this is where the trust that the patient has on you as a doctor is very important. Right from the time you meet the patient for the first time, a good eye contact and a good communication and the feeling to the patient that the doctor is open about everything with me helps a lot in their subsequent treatment process as well as their survivorship period. Because sometimes we have diseases like thyroid cancer and carotid cancer and many other such cancers in our head and neck area where we do know that this patient is probably going to be a cure for his lifetime. However, a lot of times after you're told him that you're cured, technically you're cured, your chances of relapse is very, very low. Patients will not completely believe you because of that stigma of cancer and what they heard about cancer in the past and other things and from their family and friends. So although you tell him that, when he goes out of your chamber, he is not completely convinced. So, but if that communication channel was open and he trusts you and you tell him clearly, go out, live your life. You're done with the cancer, but be on follow-up. if he trusts you, his anxiety levels, his quality of life, his subsequent day-to-day living will change a lot better if he himself is convinced that the doctor is telling me the truth and not just telling me to make me feel better. So that is one point. So an open communication channel can make a big difference to these long-term survivors who are good prognosis cases. Secondly, many of the studies which cancer survivorships we have statistically in literature is all from the Western data. Unfortunately, we have very limited Indian data, and which I think if those interested should probably try to develop, and it can be a very good addition to the Indian contribution to cancer survivorship literature. We did do a small study in our own Laryngectomy Society group, which I told you about in the beginning, in which we compared quality of life of patients or the survivors who had been taking regular part in the self-help group programs and those who have not. And we did find once again that the self-help groups made a huge difference to their overall quality of life, and we did have a significant difference between the two groups, those who participated regularly in this self-help group programs and those who did not. Although we did not publish it, we do know that, to reiterate again, self-help groups, interactions, family members meeting together, the doctors adding, contributing as medical advisors and coordinating the whole process can make a huge difference to this long-term survivorship patients as far as their day-to-day living and their quality of life and the anxieties and fears are concerned. So those are the two things I would wanted to add to what Dr. Rima has already elaborated on.
I think I fully agree with you. Two important issues I will also stress upon. One is effective communication between the treating team, the oncologists, and the patient, family, and the caregivers. Number two, we need to comprehensively address not only the physical needs that the person has to come for follow-up, but also address emotional, psychosocial, spiritual, maybe help through some agencies, the financial component also. So survivorship is not just today you have treated and the person is gone. You make a link with the patient for life. It is not like appendectomy has been done and the job is done, gallbladder stone has been removed and patient goes home, may or may not come for a visit to you. But a cancer patient is a cancer patient for life and is with you and your own baby. Okay. And thirdly, I don't know if you have read about the World Cancer Day, which is coming on 4th of February. This year's theme is United by Unique. You see, I think the theme addresses that everybody is a unique patient and his requirements are unique. We talk of combined modality treatment and personalized care being given to the patient. But personalized treatment is medical treatment. We need to think beyond the medical treatment and give other types of supports also. And this theme will be for 2025, 26, 27. You should read about the United by Unique theme, very good theme, and very good philosophy which is given in WHO this year's theme. So let us see anything in chat box. I think everybody has understood everything.
Good.
Good.
This is a little offbeat topic, so
Yes, but very important if you are practicing oncology.
Yes.
I think you have to be not only a physician, a surgeon, but a philosopher also.
Yes. Yes. And every day I deal with a lot of follow-ups of patients, of thyroid cancer patients, because as we know, they are in the 95 to 98% cure group, and many of them are young. They're in the prime of their life. There are college students. There are people managing their careers. So there's a big young population who have another 30, 40 years of their life ahead of them. And if this particular stigma of cancer is going to ruin their careers, their lives, their lifestyles, and all that, it's going to be a big problem. So, of course, I mean, thyroid cancer is one of the most curable cancers. So, it's much easier to convince them that they're completely fine. And then you have also salivary gland tumors with good prognosis. So, this particular thing which you mentioned about unique, united, we are unique. That theme is very important because the survivorship needs of a thyroid cancer and a salivary gland patient is completely different from an oral cancer patient, because it is not easy for you to completely convincingly tell him that you're completely fine, don't worry for the rest of your life. Because we know that he has much higher chance of recurrence, unless it's of course a very early stage oral cancer when things are almost probably similar to how you deal with them on the survivorship issue, like you do for a thyroid and a salivary gland cancer. But when you're dealing with an advanced oral cancer patient who has survived a couple of years, you also know that at any time in the next few years, there's a chance he may get a second cancer, second primary, he may have a recurrence. So, although the scene is not as rosy as for him, so his needs are unique as the survivorship of how you deal with him. So each of this kind of long-term survivors, you have to deal with them a little differently of how you communicate what you're trying to communicate. So this is where the doctor's responsibility sometimes becomes a little more complex and a little more important as far as how you convey your long-term survivorship goals to the patient. So this particular theme, I think, is a brilliant theme, and I think we all need to focus on that. Every cancer survivor has his own unique needs and own unique anxieties, which, as a doctor, although it can be a little complex for you, you should learn to handle how to do it if you have to do justice to your patient.
Thank you, Dr. Nayak. If there are no questions, then